We'll give it just a couple more minutes and then we'll get started. Welcome to everyone who's joined.
Raining where you are?
A little, yeah. Okay, I think we'll get started. More people will be joining, but we all know how that goes. So welcome everybody to our second workshop of our 6-part series. The series overall is setting the stage for ACEs screening and trauma-informed practices and small practices. Trauma-informed care, sorry, in small practices. And this webinar is going to focus on the physical environment and the front desk. So we're happy to have you here. Next slide. For those of you who are joining us for the first time, we want to let you know that we had one webinar, which was a review of trauma and trauma-informed care and ACEs for small practices. That happened in October. This is our second one, and here you can see the information for the next 4, which we would be happy to have any of you and all of you at. And if you didn't register for them already, you'll be getting an email after the webinar that will allow you to as well. So a couple of, I guess, let's go to the next slide and then I'll just do a couple of housekeeping things. So we'll introduce ourselves very quickly and briefly, but most of us are familiar with Zoom. We are going to ask for some participation, so feel free to use the chat box. Address where it says try to address your comments to all panelists and attendees. That way we can all kind of stay informed about what's going on. Either Angela or myself will be monitoring the chat box when the other one is talking, so that we'll try to answer questions that make sense to answer right away, or if there are things that should wait for the end, or if someone needs to interrupt one of us to answer something, we'll do that as well. So we're gonna get started. Just a tiny bit about me. So I work for Primary Care Development Corporation, which is a national nonprofit based out of New York City. However, we have offices in California and Washington, D.C. I'm currently in the New York City metro area. This project is obviously funded by the ACEs Aware initiative that's going on throughout the state of California. And we are really excited. So basically, I'm trained as a health educator, and I spent the first half of my career providing direct services in underserved communities throughout New York City and federally qualified health centers and sexual health clinics as well. I've also been training and healthcare and social service staff in a ton of different topics, such as trauma-informed care, person-centered care, team-based care, health literacy for the past, I don't know, 17, 18 years. For the past 5 years, I've worked for part-time for PCDC, and we travel all over. Well, we used to travel all over the country to provide training and technical assistance to health centers, and particularly health centers that work in underserved communities. That's a little bit me, and I'll have Angela quickly introduce herself.
Good afternoon to everyone. I think it's still afternoon. It is afternoon where most of you might be right now, right? Like Yael said, my name is Angela Fernandez. I am actually the assistant director for a New York City-based sexual assault and violence intervention program that's part of the Mount Sinai Health System. I started out my career as a sexuality educator and spent it used to be half, but I guess about a third of my career now, I'm getting older, working with, focusing actually on prevention education and working mainly with teenagers around sexual health, pregnancy prevention, and we focused a lot on healthy relationships. And that basically brought me into the world of relationships and violence prevention. I've been working with the Savvy program for many years now, and specifically focused on trauma work. So working with survivors of sexual violence, intimate partner violence, and other forms of gender-based violence, and had the opportunity to partner with Yael at Primary Care Development Corporation for about a year with a focus on trauma-informed care and person-centered care. So I'm really excited about this series and being able to work with Yael again on this, and really happy that everyone is here today.
Thank you. Next slide. So what we're gonna focus on today is thinking really about physical healthcare spaces, including the reception area, on what those spaces have, the impact those spaces have on people with trauma histories. So we're going to look at re-traumatizing aspects of physical space and reception protocols. We're going to talk about what makes up a trauma-informed physical environment and front desk experience. And then we'll be able to list some ways to improve the physical environment and front desk experience to be more trauma informed. And as you'll notice, some of these things will be things that are kind of easy to implement, that won't take a lot of effort or money. And then there will be things that are huge and, may take years and years, if they're going to change at all. So certainly just be listening in that mindset that we 100% understand that nobody is going to be able to do all of these things, and we just make things work the way we can within our context. Okay, next slide. So really kind of the big picture in this series is really looking at trauma-informed workforce, physical space, reception, the clinical encounter, screening and responding in the right way, giving control back, and giving patients choices and voices. So like I said, we'll focus on these two that are highlighted today. Next slide. Angie.
So we are going to start with a warm-up and get us back into the frame of mind of a trauma-informed lens. On the left side, you can see that we have a few examples, few quotes from healthcare staff, and expressing some frustration around some patient behavior. So I'm going to ask for people to participate a little bit. I'm going to read the first one that is going to sound non-trauma informed, and then ask for your feedback as far as what might be a more trauma-informed approach in thinking about what's going on with this particular patient. So Mrs. Wright is late for her appointment again. This is the fourth time in a row. She will have to reschedule. I'm not squeezing her in again, right? And I'm sure that many of you have felt the same frustrations as far as dealing with patients who have chronic lateness, right? So in this particular situation, the approach is to just not squeeze this person in again and just feel frustrated. what are some suggestions around thinking about what might be a more trauma-informed way of looking at someone who is struggling with chronic lateness? And you can just type it into the chat. Don't be shy. Oh, great. Okay.
Yeah.
Have conversation with what might be happening in her life. Great. Be curious as to why she might be having challenges, asking questions as to what is challenging, recognizing that Mrs. Wright might be in the middle of a crisis or many crises and can't make it. Go down to the unmet need, right? What's going on? That's what I see. I hear a lot of people saying, what's going on with Mrs. Wright? I see you're having trouble, and to address it. Okay, you all are amazing, right? So I know for those of you who weren't able to be in the first session where we really went into detail about reminding ourselves as far as what is trauma and what we might see from patients, right? Discuss the pattern of behavior, try to have a conversation. That one way to a reminder about this as a recap, rather than thinking about what's wrong with this patient, think more about what might be going on for this patient. So all of these are fantastic. Yes, these are all trauma. Oh, that's Yael. Yes, these are all trauma. Okay, let's look at the second one. This is the 8th visit in 1 month for Mr. Jones. He's always complaining about something, but there's nothing wrong with him. So again, thinking about what's going on with this person, what might be some ways that you could address this? Or does it even need addressing? Perhaps he is lonely. Perhaps he needs someone to listen to. Are we listening to him from his perspective? Ask and listen. Fantastic. Follow the pain. Yes. Yes. Yeah, listening, right? So listening to seeing what's happening, but really hearing the person. I hear listen a lot. Ask him what he thinks is causing the issue.
Someone wrote that acknowledge that our services are not meeting his needs. That's really interesting.
Who wrote that? That was Janet? That's an issue. That's fantastic. And that's such an important point because in general, right, the healthcare system is not designed, honestly, it's not been set up when the way that we're now understanding what trauma does, right? And thinking about trying to give control and power, re-empowering a patient and allowing that person to have control is almost completely antithetical to healthcare and what healthcare providers are seeing, right? There's a lot of power in the medical world. And most of the time as patients, we go and we are expected to, we expect that our providers are going to be all knowing and they know all the right answers, but we are also expected as patients to be on our best behavior, for lack of a better way of describing it, right? So totally right on point that the issue is not necessarily the patient, the issue is the interaction with the healthcare system and how it's set up and how it's impacting the individual patient. So let's look at the last one. That patient was so rude to me. I asked him to please take a seat and he refused to sit down and just started screaming at me. I told him he would have to calm down or he would be asked to leave. What do you think is the best approach in a situation like this? If you have a patient that is maybe yelling, maybe being disruptive, sit down with him, say, oh dear, you seem to be upset. How can we help? Responding in a caring way, try to empathize. What was he yelling about? Seems like the person helping him might need someone to listen to her too. That's so important, right? Because trauma-informed approach is not just outward facing. It's not just about trauma-informed service delivery. Trauma-informed care means that we have to also look within and provide space and support the staff as well from a trauma-informed lens. That's so totally on point. Yes, front staff need trauma-informed training. Great. Okay. Next slide, please. So this is a continuation of that last scenario we talked about. In fact, the patient's name is Brian, so the one that one was yelling. And just to kind of take a deeper look into what is going on with him, because clearly something was, Brian is a 45-year-old male and a new patient to the practice. He has been suffering from insomnia. He's also a Marine veteran, and he served 3 tours in multiple active combat zones before returning home last year. Brian's military training focused intensively on being able to scan and clear areas for threats, such as snipers, especially doorways and windows. This was necessary to his survival. Now that he is back in civilian life, he is suffering from PTSD symptoms where he struggles to regulate the hyperarousal response, right, which is that fight or flight, where he is in a constant state of higher anxiety and adrenaline. When he was told he had to take a seat, he noticed the only seating options available were arranged directly in front of the windows that looked out onto the street. This immediately triggered him. He became consumed with panic and terror at the thought of being exposed in front of the windows. This caused him to become angry and confrontational with the medical staff. So in thinking about the focus today, where we're talking about physical space and design, this is a perfect example of how the physical space and design of this particular office was not set up in considering trauma and considering what might be triggers for people, right? And it sounds like the only options that were available were in front of the window, which is not going to work for someone where that exposure is going to be triggering. And so we wanted to start off with this and just looking at how simply the interaction and that relationship with our physical space can either help to calm us and relieve some anxiety and stress, or it can exacerbate issues, especially people who've experienced trauma. Okay, next slide, please. So we'd love to hear more from you. What elements of a physical space do you first notice, and how do they make you feel? So thinking about when most of us, right, have experienced our own personal experiences with the healthcare settings. So doors and windows, great. Wow, interesting. So Janet, doors and windows, you can understand what Brian was going through. Lighting, absolutely. Lighting, whether it's felt open or closed, yes. Where the exit is, how close chairs are together might be threatening, yes. And how do these things make you feel? How would some of these things make you feel uncomfortable? How is that interaction with, closed seating? How does that make someone feel uncomfortable? Not interviewing sexual assault survivors in a room with stirrups, yes. Anxious, darkness, not safe. And what are aspects of this setting that you first notice that would make you feel comfortable? Options, yes. Being able to choose, yes. Fantastic. So you've set us up perfectly for the rest of the slides. So well done. And we did not have that planned, but I think that this just shows, right, that we all can, even without this training, all of us can relate to how important our physical space and environment are around us, right? And I would say that, especially during COVID and quarantine, we've probably have an even better understanding and appreciation of how important our physical space is, and the environment, and what that relationship is like, right? How it can improve or completely disrupt our ability to focus, to be productive, to feel safe, to feel calm, right? Next slide, please. And when we think about specifically working with trauma and survivors, the impact of physical space can also be re-traumatizing, can bring on triggers and really make people feel completely disoriented and unsafe. So we know that our physical space has a profound impact, right, on our attitude, our mood and behavior. And again, I'm sure a lot of us have some stories to share just during quarantining and what that has meant in our own physical space environments. And that there's a connection between physiological state, our emotional state, and the physical environment, right? And these aren't just anecdotal ideas. There's research that has been done specifically with trauma survivors as well, and what that relationship with the environment does. So we know that research has shown that in an agency that was perceived as pleasant, as beautiful, well-kept, neat, calming, a lot of the things that you mentioned were considered more professional, they were considered more believable, and the perception was that they offered a higher level of customer service in handling a customer complaint than one that was perceived as disorganized or unpleasant, right, or unkempt. And that the physical space is the first thing that we notice when we enter a building or any setting, right? And it comes in, the fact that I'm a clean freak comes in handy when I have guests over, because even though it exhausts me, I'm hoping it makes other people feel very safe and comfortable. And there's also there's an interesting Harvard Business Review that showed that a messy workplace impacts workers and threatening their sense of personal control. So some of you mentioned earlier, some of the things that are most helpful to you and that make you feel the most comfortable are options and feeling like and choices, right? Which essentially means that you have some control over your environment and how it can impact you. And that is key. That's at the root of what a traumatic event is. It's the ultimate loss of control, right? That creates the lack of safety and the threat. And so we want to do whatever we can and think about ways that we can create a feeling of patient safety, and where patients have a sense of some control over their experience when they are in that healthcare setting. And the physical space is just one element of that. The other thing I just also want to mention is that this, right now we only have an hour, so we can't go into detail about this, but really remembering people who are living with a visible or an invisible disability as well, that, a disability in itself is not necessarily a trauma, but when people who are living with disabilities are up against obstacles constantly in their physical environment, that can be traumatic in itself. Next slide, please. So what is trauma-informed healthcare design? There's actually a very official and formal definition on it. And really what's at the root of it is that it's incorporating empathy, a sense of calm, safety, dignity, empowerment, and well-being. And it really accomplishes this by adapting things like spatial layout, thoughtful furniture choices, visual interest, the light, color, what type of artwork do you have on your walls and around, and then natural elements and how that can be incorporated to connect to the outside or the natural world, things like plants or flowers or fish bowls, right? And I want to just emphasize the piece around dignity, right? Because the definition of dignity is about a state of quality, of feeling worthy of honor and respect. And for many trauma survivors, one of the things that is lost and it's disconnected from a person is that feeling of self-worth and self-respect, right? It's usually replaced with feelings of shame, with guilt, with self-blame, with being self-conscious, with feeling disconnected, right? Something's wrong with you. And so I think that this piece of dignity is so essential as well, because that's really what we're trying to do, is to treat each person that they are worthy of our respect. And the physical environment is an aspect of that. Next slide, please. So trauma-informed design really aims to promote certain things, and we want to minimize and remove other things, right? So by minimizing adverse stimuli as much as possible, environmental stressors, re-traumatization, and loss of control, we can then promote and support safety, well-being, healing, and dignity. Does this mean that all of a sudden all of our office space and our medical space have to be completely knocked down and rebuilt, and you need a new shiny office and equipment and everything in order to accomplish this? No, not at all, right? I think Yael said earlier, it's about also working with what we have, things that can be improved upon that are in our control, we do. But also it's recognizing some things that are beyond that, right? That are just part of the system or part of other things that we might not be able to fix. But if we are thinking in a trauma-informed way, we can also help to provide better information to our patients. We can let them know that there are things to anticipate that might be upsetting, right? So this is also just about increasing our own awareness of these things so that we can anticipate what might be a challenge and what is out of our control to be able to fix. Next slide. And this really just reinforces the last slide. So things that might hurt are congested areas that are noisy, right? Poor signage that's confusing, uncomfortable furniture, dirty furniture, I would add to that. Separate bathrooms. So separate bathrooms meaning bathrooms that are specific only for patients and only, or only for staff, but it's done in a way that almost feels that it's alienating toward patients, right? You would never want to share a bathroom with your patients type of thing. But again, we might not want to change that because our staff also need to feel safe and respected. So there are things that might be upsetting or triggering to some people. It doesn't mean that we change every aspect of it, but just thinking again in a bigger way of how some things we might not think about or do work well for some groups or populations might actually not work the same for other populations. And that's important to just know too. Who is your population? Who do you see most often? And trying to make decisions that will suit kind of the most amount of your patients. But what helps? Comfortable, calming, private rooms, furniture that's clean and comfortable, no wrong door philosophy, messages conveyed throughout that are positive and hopeful, right? Really just engaging the senses is really what it's about. Next slide.
Okay, so thanks for all of that, to set us up for really looking at what are the principles of trauma-informed design. So the spaces that we're going to be talking about today are the outside area and/or parking lot, depending on where you are, the reception area, common areas like hallways and bathrooms, treatment and exam rooms, and then staff spaces. So next slide, please. So each of these elements that are on this slide really need to be considered for each space. So let's take a look at what each one is about. But before we do that, I want to say that these guidelines are general, and as we've been having some chat already, they're not going to work for everyone. We're going to see a really good example of that in a minute or so. So obviously, it's really best to consult like your team, your patients, and the community about, what would they like to see? What would make them feel respected and safe? Okay, next slide. Okay, so when thinking about spaces that are used by people from a particular community, it can be helpful, really helpful to engage members of that community about what kinds of images, what kinds of art, and what kinds of colors make them feel, calm, relaxed. We don't have to look, far for these kinds of examples. We all talked about things in the beginning that make us feel comfortable or uncomfortable when we enter a space. We can't always represent art and decor for every cultural or ethnic group that we serve. some of us work in incredibly diverse communities where this might be impossible. But also many of us working in more homogeneous communities where really this might actually be more doable. In general, we want to try to avoid abstract art. It leaves too much for interpretation, and it can make people feel, uncomfortable. We want to always be sure that we have materials and signs in the languages of our patients. I know that's totally obvious for most of us, but it's still amazing how many places, don't do that. So I think one of the reasons this is so important is that nothing really makes a space feel more unsafe as when you can't read or understand anything on the wall or any of the forms that you're given. So, just think about that. Next slide. Okay, this is a big one. So in terms of layout, furniture, and sight lines, what we know is that spaces with clear sight lines, high ceilings, which someone also mentioned, and minimal barriers are usually perceived as being safer and more relaxing. And because you can see further away, there's a sense of control or safety. You'll be able to see something kind of coming at you. Making spaces as easy to navigate as possible with clear, consistent signs. This really means that signs for things like the labs or the restrooms should be clear and use the same language throughout. So for example, you don't want to have a sign that says, like, let's say restrooms this way, and then the actual restroom is labeled bathroom or women's room or, something else. That's kind of a health literacy principle, but it's also a trauma-informed principle. So having furniture face away from the walls, this promotes, sense of safety so that, your back is against the wall. It seems pretty obvious, but people will feel safer with their backs to the wall, so they can't be surprised, right? No one can come up on them. Avoid having people sit face to face. So people who don't know each other, right, in the waiting room. So this can sometimes be, if they are sitting face to face, it can be perceived as confrontational. So clustering seating is a better choice if you can do it. Cornered seating is also really good. It can invite socialization and interaction for those with others. So if you're in, let's say, a pediatric setting or even an adult setting, you have someone with you. If there's a space for the two of you to sit together where you feel like you can talk but still have some privacy, that is an important option. Secluded seating options are also a good idea if you manage them, so people can choose to be a little further away from others and have more privacy. And obviously the furniture should be clean. Hopefully it's comfortable, and hopefully it's big enough to accommodate different body sizes. And this always makes me feel like, although many of us probably haven't been on an airplane in a very, very long time, but when I was flying and traveling a lot, I felt like every time I went in, the seats on the airlines were getting smaller and smaller, and not really taking into account what's happening to Americans, which unfortunately, we're often getting bigger and bigger. And I would see people, who were bigger struggling with, the seatings, and I just felt like my heart just broke for them. So again, we want to pay attention to that. Next slide. Okay, someone asked earlier, what colors do we consider to be calm? So we'll get to that in a moment. So here we're thinking about giving people something nice to look at, right? It's a good idea. It can distract them. It can actually ease stress, and it can actually improve mood and comfort, depending obviously on what it is. Nature is generally universally soothing. Of course, just like everything, it's not going to work for everyone. And maybe something happened to someone in a nature setting, so maybe that could be triggering for some people, but in general, trauma-informed design says that nature is sort of where to go. Also, you mentioned the fish tanks. We see those in a lot of places. And according to the designers who design healthcare and other spaces, deep colors should be avoided. So these are reds, oranges, and yellows. Those should be avoided. And the ones that should be used are what we call cool colors, which are blue, green, and purple, and apparently they have a calming effect. They're also seen as making spaces feel more open and less crowded. So this may also seem obvious, but avoiding stark white walls, right? They're institutional. They can remind people of places like prisons, other kind of institutional places that they've been. And finally, if possible, have some plants, use some plants. Someone write, I always put fresh flowers on the front desk. That's so nice. That's fabulous. Next slide. So thinking about what we hear and what we smell, these are things that are really important, although we often don't think about them playing such an important role. So we generally want to minimize loud and overwhelming noises. Now, depending on where you are, this may or may not be possible. I worked my entire career in New York City in health centers, and there wasn't always a way. One of them was under the train tracks. And so you would hear the subway, in the Bronx going all the time. And that wasn't nice, but it wasn't something we could do anything about. Sorry, I lost my train of thought. It's fine. Consider playing music, right, that incorporates natural sounds like the ocean, breezes, things like that, and limiting control of the smell if possible. So really not having staff, especially in the reception area, eating their lunch, while they're working, or having something that has a strong smell to it out there. Again, seems obvious, but we know what happens in a busy day in the clinic, and we don't actually get to take our lunch, and we kind of just have to eat, on the go. I know some practices have TVs on, and sometimes they show news and sometimes they show daytime talk shows. I remember this was a constant argument between leadership at a network of 12 federally qualified health centers that I worked at. They would say, some people would say, well, the patients want, whatever it was, whatever the daytime, talk shows are. I don't even know what they are. And then other people would say, well, that's not appropriate. We shouldn't have that in the clinic. So it's generally not the best choice to have the news or one of those types of shows. There are some places that have the TVs with like health messages on them. And there's even some companies, if you're interested, we can get you some information about it, where they actually provide free TVs and you can put in your own kind of empowering health messages, things about, eating healthy, or, reminders about getting, a mammogram or whatever. Okay, next slide. So lighting, this is actually something that we can often change easily, because sometimes it's really just like the change of a bulb, and it can make light less harsh and institutional. So if you can, natural light is preferable, and spaces with windows, assuming you can still maintain privacy. Now, this is where in the case study that we discussed earlier with our veteran, windows were not okay for him. Windows were totally triggering for him. So again, this is just another example of how we can't make everything perfect for everyone, but allowing those choices, right? Maybe if there was somewhere else that he could have sat, and if he was looking at the window and he didn't have to sit next to the window, that might have been better for him. Let's see. Right, so avoiding lights that hum, buzz, or flicker, avoiding those fluorescent lights. Certainly if there are windows, there should be blinds on them, depending on what the windows look out to. And you can get the blinds that are the light filtering, meaning you still get the light, but you also get the privacy. Using LED lighting, if you can incorporate natural lighting, is really helpful. And using lamps as needed for filling out forms. Okay. Someone is writing, yeah, disinfectant is a problem with smell. Yeah, health messages can feel coercive. Yep, it depends obviously on the tone of like those messages, certainly. All right, next slide. So some of these things may be easier said than done. Unless you're undertaking a full makeover of your space, you may not be able to make the space easier to navigate. However, you can add signs, perhaps, or arrows on the floor or the walls. And if you have a confusing clinic, you may just want to be sure to escort patients from one place to another. I don't know about you, but I feel like it seems to be a prerequisite to building a health center to make it as confusing as possible. And anytime I go somewhere and I leave the exam room and they say like, okay, bye, you can go to checkout, I literally have no idea where I'm going. And I find myself just walking around and eventually having to ask somebody. This is really not ideal. And if possible, have a separate space for patients who are in distress, right? Even if it's an empty exam room. Obviously, patients who are having a hard time will appreciate this effort to keep their emotions private. And also the people who would be witnesses to it, may also appreciate that, because that may be, that may also be re-triggering or just uncomfortable, right? Just uncomfortable for people who are witnessing that. Okay. I know there's a lot of stuff coming in on the chat, Angie. I'm assuming you're kind of monitoring it. I can't keep up. That's a good problem to have though. Next slide. Okay, so let's talk about the physical space and the new normal. I think most of us know these things. The main thing we want to stress is that even though many of the tools and procedures that we are being forced to use to keep everyone safe, they're often scary and triggering, we can do it in a way that it's trauma informed. So I just learned that there are those thermometers that can read your temperature on your wrist without making contact. I didn't even know those existed. I'm not understanding why every place wouldn't use those instead of the ones that look like, the gun pointed at your head. We can ask permission, right, to take temperatures. We can explain why we're doing it before we do it. We can offer hand sanitizer and masks, and we can be sure whatever we're saying verbally is really, we're speaking in really plain language, okay? We no longer have the benefit of reading people's facial expressions or their lips when they're talking. So we wanna really try to minimize confusion, and by using plain language, we can do that. So, right, how do we clean magazines, right? We can't necessarily, but sometimes there's, I've just seen those like shields that you can put on some of them. And I think after a certain amount of time, if they're just out, then they're considered safe. So, okay, yeah, next slide. Okay, so thinking about for those of you who work with young people or children or in pediatrics, many of the same principles still apply. However, we want to highlight a few things. Thinking about furniture, right? Is it kid friendly? Meaning, is it sturdy? And can children of different sizes access it easily? And can families sit together in small clustered seating, right? And are bathrooms designed for adults and children? In terms of books and toys for kids, again, they could still be offered, but perhaps they're behind the desk and offered individually and then cleaned, after each use. Okay. All right. Okay, so let's take a look at this. I love this. And I'm just looking at time. We're good. So here are two spaces. Which one is more trauma informed and why? So feel free to chat in. You could say, the first picture, the second picture. Right, because of non-confrontational seating. Good. The second, yep. So let's hear some reasons why the second. First on. Right, because of the lighter colors. Yep, so the colors are lighter on the second one, and there's no abstract art, right? So in the first one, we see very abstract art. In the second, there's good seating and signage, right? If there's a welcome, there's a sign for exit, there's plants. Yep. Mm-hmm. Not face-to-face on the second one, absolutely. What about, look at the reception desk in the two and tell me what you see there. The desk is safer, yes, but how so? Right, the right also has a kid space and clearer signage. Trash is not full. Yep. You see on the left one or the first one, there's trash overflowing or trash that got thrown on the floor and not picked up. What about the reception space?
Mm-hmm.
Desk is open with no clutter. Good. Right. So is that Shaka? The confidential papers on the desk, right? The first one, right? We don't, obviously we can't see exactly what it is, but they're trying to show us that something has been left out there that may have, you know, identifying information of a patient, and that's probably not cool. And yes, Deborah, the computer on the first it would be able to be seen, right, by patients, as opposed to the one in the second, where really that has more privacy. A welcome poster that's inviting. Yep. The temperature, yeah, it seems like that's sort of a weird one, I thought, this temperature thing, but yes, it seems like in the left, it's very hot in there. Although I don't know if that's, you know, I don't know what the temperature goes up to, but yeah, it seems like the temperature in the second one is better. That large pot is a good weapon though. Okay. Any other thoughts? There's also, did we say there's pictures in the second one of lands of nature? Good. So you can see kind of a lot of the things that we talked about. You can see them play out here. Okay, next slide. And the next two pictures are really just some spaces that have been designed by companies that specialize in trauma-informed healthcare design. So I just wanted to put them up here for you. This is obviously a waiting room. Can anyone react to it? I mean, I think like there's nice calming colors. The seating is seems pretty good. For some of you, it looks very cold. I kind of like it. The reception, you can see the reception, right? They're kind of at the same level, clear sight lines. One challenge might be hearing your name called. Yep. I was talking to someone the other day, and I don't know why in healthcare we can't use like the things that they use at the Cheesecake Factory. You know, when there's a wait and they give you the thing that lights up. I think we should do that in healthcare. I'd worry about the seats behind other seats. Okay. Yep. But there's definitely choices here. All right, next slide. And this is really the same. It's just a different view. So you can see that there's some other seating options over here and how kind of clean and organized the front desk looks. Okay, next. All right. Oh, front desk. No, go back. One back. Angie, did you want me to do this one?
No, I'm ready to go.
Okay.
So I think that some people said in the beginning that the front desk and reception make the first impressions, right? So we're going to segue into thinking about the front desk experience. What do you think about that picture right now? In just thinking about all that Yael went over as far as trauma-informed design, how does looking at that as a front desk experience make you feel? Messy. Mm-hmm. Makes me anxious. Yeah, I'm right there with you, Matthew. Zoo-like, cluttered and messy. Yes, anxious. Absolutely, right? And then how many of you had desks that kind of look like that if you've had a busy week of work? I know that I've been guilty of that in the past, right? So this is also, we're obviously going over things. I will lose my info or papers, absolutely. But yes, right? I mean, this is none of what we're talking about is to make anybody here, right? We have to work with what we have. And times that we are not meeting this bar all the time doesn't mean that we're terrible people or being terrible to our patients, but it's just kind of reminding us to be mindful that our space is not just our space, but our colleagues are experiencing our space, our patients are experiencing our space, right? And sometimes our space is impacting us and we don't even realize because it's been that messy for so long, right? And what might it feel like if we did organize and get rid of the clutter? And maybe that would change the way we're feeling about our own work environment as well. Next slide, please. So before even coming to the physical space, right, we have to think about how those initial interactions are setting the tone for what it's going to be like when people actually get there. And so a lot of this weighs heavily on who our front staff, our front desk workers, usually our reception staff, really on them, right? So thinking about, are our staff friendly and warm, and do they not rush patients? And more importantly, are they not forced to rush patients, right? Because it's also about how the entire practice is set up, right? If we want to set our staff up for success as well. We want to make sure that our staff are using plain language, that Yael mentioned earlier. It's so important. Speaking slowly, limit the amount of personal info that's asked for. And I know that that's a real challenge, right? When we have to get a lot of information and insurance information and all that, but are there ways to limit the amount of personal info in those initial interactions? Let's try to have more flexible cancellation policies. I don't know about you, but I have felt so shamed and penalized, right? At times when I've had something come up, or maybe I'm having a hard time and I've had to cancel an appointment that's less than 24 hours notice, or I've arrived to an appointment 10 minutes late. And the tone is like, you have failed as a patient, right? So having some flexibility is really important, being clear about it, but also not being so punishing of patients in our tone, right? We don't want to set up this dynamic where there's where there's an anxiety just in these interactions and how it might make someone feel. Navigation of phone prompts should be easy to understand. That's the most frustrating thing to me. I feel like when you have to push about 7 different buttons to get to something, or maybe you don't know what the right prompt is. And if you don't pick a prompt, you get nowhere, right? All of this creates obstacles, and especially can be very re-triggering to people. Is music played on hold? But what kind of music is it? The amount of time that someone's placed on hold and other options. And then, really important, the directions for once a patient arrives. Do patients have to go through a security entrance? Do they have to pass by a security guard? Is it a door that's buzzed for you to get in or out? These things can be very traumatizing to someone. And it's important to let people know ahead of time if there are special circumstances. Also things like, parking in the entrance, and obviously right now with directions about COVID. And, I also think things like if you have a building where there's no elevator, or an elevator is not an option at that time, it's important to let people know. We can't make assumptions about people's accessibility and what that means too. Next slide, please. So general guidelines, again, it's really about tone, right? And going back to that word dignity, are our policies set up to make people feel that, to help people have dignity? Do we treat people with respect? So we want friendly and warm staff. We want people while greeting patients, and to slowly guide people through the registration process. We don't want to be irritated when a patient has a question about the forms. We want to be organized and have clean spaces. the explanation of forms, again, have them in plain language and to be ready and have assistance in filling out those forms. We want to let patients know ahead of time what the expected wait time is and why, right? I had a dentist appointment recently, and I was calling, and it was because I was having pain, right? So when I called, I was like, I really need to see this dentist. And I found that once I was talking to the reception and they made my appointment, they also said to me, because I haven't been there in a while, that the dentist is literally like she's like 8.5 months pregnant. And they let me know, even though I was getting the first available appointment in the morning, they gave me a heads up that she's she's traveling a little slow these days. And they were letting me know that there may be a little bit of a delay. And I think, and part of it was in response because I was calling with such urgency to get in, right? So that let me know not to have these expectations. If I got there a few minutes, if I get there and I had to wait a few minutes, that was totally fine. And I was able to mentally prepare for that ahead of time, right? So that's just a small example. It's not a big deal, but it really did set the tone differently for me, right? Checkout should also be warm and friendly because survivors may have been triggered during the visit. Coming to the doctor can be very, very triggering for people. There's a lot of anxiety, right? Except for preventive appointments, most of us are going to the doctor because something feels wrong. And then we want to take time to train all of our front desk, appointment line, administrative staff in trauma, right? And again, this also goes back, if we are not practicing this like internally within our practices and with our colleagues, it's going to be a lot harder to also approach our patients with this, with being trauma informed, right? And also, like for training, I would also suggest training on cultural humility, right? And I'm not saying cultural competence, but cultural humility, and how certain aspects of our cultural identities also are intersecting with our experiences as trauma survivors and with the healthcare experience. Next slide. And these are some other some other trainings for front desk team, right? So trauma and impact of trauma, of course, customer service. Sometimes we forget because we're working in healthcare, but patients are customers, right? And so customer service is very important. Communication, we're suggesting something like OARS, so open-ended questions, affirmations, summaries, and I'm forgetting what the R one is right now. Rephrasing, there you go. Health literacy in plain language. How to manage a challenging or hostile patient. Earlier, when we were talking about Brian, someone said, maybe someone also needs to talk to the staff person, or that person might need to talk about having that confrontational interaction. Absolutely, right? So, it's hard for us not to take it personally when we have some confrontations with patients. And so de-escalation techniques and training can be really helpful. How to build trusting relationships, role plays with feedback, or absolutely, if you're not putting into practice, it's really hard to actually get it. And then incorporating some of this into performance appraisals and the process, right? We want to incentivize people and our staff that there's also a point to all of this as well. Next slide. So communication, right? It comes down to that all the time, everywhere. So greeting everyone, we want to use names and we want to greet individually if possible, right? We want to acknowledge someone when they first get to the front desk as well. How many times have you gone to a front desk or a customer service desk? You're standing there. The person who's behind there is not acknowledging you, and you're just, right, your blood pressure is just increasing as you're standing there and watching this. There might be a reason why someone's not addressing you yet, but we don't know, right? So let's acknowledge someone, at least with eye contact, if we can't greet them verbally right away. Explain who you are and what your role is. Be self-aware of your own mood and responses and give patients your full attention, right? Again, we're not superheroes. You might be having an off day, especially with everything else that's going on in our, globally in our own environments. We have got to also acknowledge that we're all struggling, right, with our own resources and keeping ourselves from becoming depleted. Use an empathetic tone. Plain language and teach back method is so essential in communication, and also gives a sense of control to a patient, right? And then recognize stress and respond. Again, with Brian earlier and some of the trauma-informed design, if we can carve out a space to address patients if they're having a moment, that helps. Motivational interviewing techniques, all of these are helpful. Next slide. Some of these, so these are the small practice considerations. Lots of no-cost training is available online and in person, especially now, right? A lot of things have gone virtual, and this is a great time to take advantage of those free or low-cost trainings. Volunteers can help with greeting patients and filling out forms. Walmart has done an excellent job with that, by the way. Use staff meeting time for continued training and trauma-informed care discussion and planning, right? We want to really live what we're talking about here. Consider partnering with social work or public health program at a local university for volunteers or special projects. It's an excellent idea, and sometimes like medical schools as well. They're really
It's free.
Yeah, free, and they're looking for these opportunities.
Mm-hmm.
And if you need a total makeover, consider getting community donations of furniture, visiting estate sales, display artwork from a local artist, or even patients, which is a fantastic way to engage your community. Next slide.
So how do we begin? Well, we have to assess our spaces, and we have to assess the operations and the reception and the front desk areas. So next slide. So fortunately, there are tons of resources. People can look, those of you in California, or you don't even have to be in California, you can look at the ACEs Aware website for lots of resources. There are these fantastic assessment tools that the National Council for Behavioral Health has put together. They are oftentimes many, many pages and incredibly thorough. But so we just kind of did a screenshot of one page here. But it goes into very, very specifics, right? Like a welcome sign was posted, right? The initial greeting at the agency was welcoming. So very specific things that can help you figure out how you're doing and also where to start. Because obviously, like we talked about earlier, right, that there are things that are going to be easy fixes. Maybe we can change a light bulb and make the lighting a little bit softer. But then there may be things that are really a long-term vision or a long-term plan, or even just something like, hey, we can't do that now. But even if we can't do it now, maybe we can do something else that makes, this one element that we have that's not so great feel a little less uncomfortable. So next slide. So we are, as many of you know, and we went over by 3 minutes, but we are here. We are staying on to answer individual questions and to chat. We also have our small practice expert, Anuja, who is on the line. So we have, the three of us that are happy to stay on and have a discussion with anyone who wants to. If you don't want to, that's also okay, or maybe you can't because you have to get back to work. That's understandable. Thank you so much for joining us. We really hope this was helpful to you. It will be recorded, so if you want to revisit it or you want someone else to look at it, it will be on our website. I believe Kimmy will be sending out an email with all that information. She usually does that. And yeah, that's it. Keep up the great work, and we really hope to see you next month, where we are talking, what's next month? Is it screening? I can't remember now.
Yeah, the clinical encounter, exams, tests, and procedures.
Yeah, so this is going to be a great one. This is going to be all around like, how do you touch and where do you stand and what do you say? So for any clinicians or anyone who's interested, please join us. We'd love to have you.
And just a quick note, once you exit the webinar, you should be redirected to our evaluation. I've also put a link to it in the chat in case you want to get a jump start while you stay on to let us address your questions.
Yeah, thanks for that reminder, Kimmy. We really do pay attention to the evaluation. It helps us, improve and figure out, how to meet your needs better. Kimmy, do they have the option of unmuting?
If somebody types in the chat that they would like to be unmuted, I can go ahead and do that.
Okay. Yeah, so Avery's asking, the calendar invite is for 2 hours, right? So the idea is that the training or the didactic portion is going to be about 1 hour, give or take, and then we have this whole other hour to stay on, just for people who want to talk about, individual needs or challenges or get advice. Yes, the slides will be available. Oh, there's someone on there who.
Yeah.
Angie. We all know Iona.
Yes. We've since 1984. That's so amazing. Thank you, Janet.
Yeah, this is really interesting for those of you who are still on. Andrew is writing that one of the most useful things that he did personally in terms of assessing our clinic as a clinician was just sitting with our front desk staff whenever I had time, listening, helping out. It was really eye-opening and not the same experience info I'd get in the clinical room. Yep, it helped me know what patients were experiencing before they got to me, and also how I could support front desk staff and trauma-informed care. That's awesome. I think anytime we can observe or help or put ourselves into a different role within our health centers, it's really eye-opening and helpful.
Absolutely. And actually, Andrew, that's such a great it's such a great example. I had something similar with the person who is our front desk person. She's amazing, right? She wears many, many hats. And so, and unfortunately, sometimes we put a lot of responsibility on our kind of our frontline staff, right? But they're the people that we usually give the least amount of training and support to, when they're really, handling all kinds of calls. And what I learned from it was that people were really confiding and sharing a lot of information in that initial call, because of the way that she was interacting with them, but she had actually not even gotten formal training. So it was an eye opener as far as making sure she had the support as well, after hearing a lot of people's initial disclosures.
Yeah, and someone asked about social work by volunteers by the front desk. So I think one of the things that I was thinking of that I've done is usually social workers, public health, and maybe medical students, although I don't know that it's as much. They have to do some sort of like practical, I don't know, they call it like a practicum or some sort of volunteer experience, but within a real healthcare setting. And they get credit. They have to get a certain number of hours. So it was the best. I used to run these programs. I did it for public health since I have a public health background. And I would basically get all these projects done that, I never would have had the money to pay anyone else to do, evaluations and different presentations and things like volunteering to help people, during different clinic events. So there's stuff out there. There's people willing to do things. And I think especially now, because there's never been, for the most part, I would say there's never been more recognition of healthcare providers and healthcare staff. So I think people are even more eager to contribute and help in any way they can. So I know Shaka asked about where to sign up for the next session. So we've been putting that in the chat. Thanks, everybody. One hopes COVID will demonstrate the importance of home health aides. Yes, Absolutely. A very underappreciated group of people who work incredibly hard for not very good pay and benefits. I know at least in.
I'm gonna go ahead and unmute everybody. If you
Oh, great.
don't want to talk, you can just mute yourself, please, to avoid background noise. But I think it might be nicer to have a little bit more of a discussion if you're going to stay on the line.
That's great. Thanks, Kimmy.
Thanks, Kimmy. Now we're starting to see people's faces. Awesome.
Are people doing just what's everyone doing with space and front desk stuff around trauma? Certainly we didn't cover everything. So if there's things people want to share with each other, with us, we'd love to hear from you.
So if you'd like to come off mute, feel free. If you're not quite sure how to do that, just pop it in the chat and I'll try to explain it for you.
This is Chaka. I was just going to say we're getting ready to move to a new location. And so this was helpful to just be aware and think of the different ways that we can make that space more trauma informed and trauma aware and give choices. So it was excellent. Thank you.
Oh, you're welcome. One of the things, and I didn't talk about this in the beginning, but one of the things that PCDC does is we have a department that makes loans, low interest loans, to primary care and healthcare providers in low income neighborhoods or who are serving underserved populations. And we recently did a loan to, I think it was an FQHC in New Jersey, I want to say, specifically for them to get some money to kind of revamp like at least their waiting room and some of their physical space. And they wanted to make it trauma informed. And that was really, really interesting. And I think that was the first, that type of project we had done. I wasn't really that involved in it, but I thought that was really interesting and cool that people are definitely thinking.
You know, I was thinking things like just so simple, especially with COVID too. You know, is there sometimes if you are in an examination or whatever, and you do have to take off your mask, even providing a safe and clean place where someone can put their mask down. You know, we're like, now that we're always wearing masks, we're stuffing them into our pockets, we're holding them in our hands. They're not, you know, and that's not exactly the best practice in thinking about why we're wearing masks. And I've started to see even things that are, you know, just thoughtful and intentional in that way that really can make a big difference in how a person's experiencing the visit. So.
Someone is asking any ideas on how to be trauma informed, but also consider COVID safety measures. I mean, for me, I think really the main thing is explaining why things are being done, as opposed to just doing them and assuming everybody knows. Many of us have gotten used to the thermometer, you know, to the head that, you know, feels like a gun. But at the same time, we shouldn't assume that everybody knows that or that they're expecting it everywhere they go. So I think we obviously have to keep some of the COVID safety measures, but just try harder to explain ahead of time what will happen, and then also before it's done. Ponder those awful dental chairs where the dentist looms over you. Yeah. The dentist is that's hard though, right? I'm not really sure how they avoid that. But I definitely have had tons of different dentists, and they're very, very different, right? Some of them kind of just go in and start, and some of them tell you what they're going to do. And my dentist now will say, you know, raise your hand if you want me to stop at any time, or if you're uncomfortable. I'm going to take breaks throughout. So I think those are helpful. Any other thoughts?
Even in just how, going back to that question about COVID safety measures, like even how you're doing the COVID screening, you know, how are you delivering the questions, you know? You know, there's some things that we just have to do, and it's part of healthcare, and most of the time it won't be a surprise by patients. But I think it is more around the tone and you know, and really engaging and having this mutual type of relationship and collaboration with patients, rather than the way that healthcare has traditionally been set up, where there's one person who's just completely in charge and the patient is just expected to be compliant. And I think wherever we can do those things, even with the COVID screening of, you know, I have to ask you some questions, and taking time to really let people answer honestly, rather than those leading ways, like, you haven't been out of the state in the last 2 weeks, have you? And almost seeming so annoyed that they have to do this screening all day, which I know it is annoying, but it's not the patient's fault that that's happening, right? So.
But then also, like, the practice in itself, having that awareness that it's challenging for staff too. So can they get breaks, right? Are they like, do they switch, you know, is there a way to switch roles so you get, you know, a little break from that, acknowledging that it's a lot, you know, things like that as well.
Janet, yes, a childhood dentist was your model of explaining things. You know, and I have a very positive memory of my childhood dentist as well. I don't know, maybe that's maybe, you know, I think that sometimes when we're even trauma informed approaches, a lot of it has come as well as from, you know, how we interacted with children first. And then Andrew, yes, such a good point, that when we're in our own space day to day, we become you know, immune to the surroundings. So but when you can take a look from a different perspective, sometimes things might stand out to you that didn't stand out before, or you become more motivated to make a change. You know, I mean, the other aspect of that, we're all busy and working hard and taking care of other people, and so sometimes, you know, the physical space is then at the bottom of our priority list.
I've told this story before, but I don't know why there's the dentist, I guess, is the theme right now. But when I moved out of New York City to New Jersey, I started a new dentist, and she was by far the best dentist I had ever been to. She would ask so many questions about our lives. She saw my kids too. I never met anyone so kind, like, who was a dentist. She retired, and she handed over the practice to a different dentist who's also fabulous. Now, there was nothing wrong with her waiting room. Her waiting room was fine. But one day I walked in and they had revamped the entire waiting room. They had this like super cool, modern, purplish couch. I know it was a deep color, but still. And then these really neat chairs with a new floor and a coffee machine. They took it away now, but coffee machine and a little cooler of water. And I remember thinking to myself, wow, he really cares about us. And I don't know if that was true or not, but just the way the space made me feel was like, wow, like someone actually thought about the space and really changed it. Not that there was anything wrong with the way it was before.
See, yeah, you just exhibited it, right? There was dignity, and you felt like people respecting you, right? Yeah. I do think there is you know, just the intentionality of these things does go a long way as well. Even if it's a small detail, the intentional aspect of it that patients feel is really, I think, what makes has the impact, especially for some people who have had trauma in their lives. I guess the dentist is a good example because, dentists traditionally that's a very anxiety provoking visit, right? For many people. So,
But I also think they also have an opportunity to do things that other healthcare providers don't, because they still sort of live outside of the traditional health insurance like world, right? And somehow we all accept that they don't take a lot of insurance for things. Anything else?
thanks, Janet. Yes, it was fun. Thanks for joining us. Hopefully everyone will be at the next session as well.
Yeah. The next one's going to be fun. We're going to have a lot of pictures, kind of like we did with the spaces, for you to figure out why one is more trauma informed than the other in terms of exams.